Hi, this is Brad Power, and this is our weekly session of the Cancer Patient Lab. Today, we're honored to have with us Jane McLelland, who's a pioneer and leader and thought leader in the area of metabolic approaches and starving cancer and nutrition. We've actually been looking forward to this conversation for some time. And let me just cover a few quick housekeeping notes that we have at the beginning of every session. The first is that this is for information purposes only. This is not medical advice. What we try to do is arm patients with information that they can take to their medical team. Secondly, this will be made public. So if you're concerned about your image or what you might say or your name being shared publicly, you can change your name, hide your image, and don't say anything. But all of this will be made public. And finally, we are a nonprofit, patient-led volunteer organization, so we always appreciate donations, which you can do through our website. So just to introduce Jane, I don't know if Will introduced me to you, Jane. I think many people have introduced me. Oh, it was Babcha, I think, actually made one of the connections. But you're well known as a leader in the field, and so we're very interested in hearing what you have to say. We've had a number of sessions about integrative oncology, nutrition, complementary therapies, from Donald Abrams at the UCSF Osher Center to Nigel Brockton at AACR, I believe it is, to various people, Babcha included. We have, I think many of the people here have a good understanding of your work and are looking forward to hearing what you have to say. Our typical format is that we have, like, let's say 5 to 10 minutes of basic introduction and key messages, and we try to spend the lion's share of our time with discussion. So people should be either, we'll use the raise hand feature with questions or the chat feature.
Okay.
So turning it over to you then, Jane.
Right. Okay, share screen.
That is working.
Yeah, we there?
Yep. Can see that.
Okay.
Thank you.
So that's my disclaimer. As you also did, it's important to make sure that people know I am not a doctor. I'm not a pharmacist, and these are only suggestions and things that I have done for myself. So this is me, former chartered physiotherapist. I haven't worked as a physio for a long time. Stage 4 survivor, it came back multiple times. Patient advocate, educator, and author of How to Starve Cancer, which looks like some of you have read. Hurrah! And I also have an online course. I'm going to do a special discount for you, Brad. So I'll do that straight after. I'll put that as a discount code if anybody hasn't seen my online course. I don't know whether that's something I'm allowed to do, but I've just done it. Okay, so I'm most known, I think, for my Metro map, which is kind of a metabolic, quick look at what is happening in the cancer cell. So it's essentially looking at the 3 macros in the diet. You've got glucose on one side, glutamine and other amino acids on the left, and then along the bottom, there are fatty acids. Okay, so that's a very quick snapshot, and that's what's kind of given me probably the best, I think that's, I can't say famous, but people actually recognize me for the Metro map. That's what people know me for. That's a more up-to-date one that I did, and it's got some more pathways on there. So I updated my book in 2021. So I've put some transport on there. So lactate transport. I've also got glutamine and other transporters, amino acid transporters like the XCT. I do a full chapter on ferroptosis in my 2nd edition as well, and fat transport as well. So a few other things going on in there, which hopefully paint the picture of what's going on with the metabolism of cancer. But people don't really know this section of what I talk about, which is cancer's progression, or my précis of the hallmarks. The hallmarks now are, what, I don't know, about 18 or 20 different hallmarks with emerging hallmarks, including the microbiome. This, I've kind of chopped it down to these as my approach to try and look at how they all fit into the progression. Because when you look at the hallmarks, they're always denoted as one sort of round circle. And there's no start and no finish to it, but I've tried to break it down into what actually happens. Okay. Someone's singing in the background. Anyway, so we start with the abnormal environment. That's what is going to cause cancer. Cancer starts in the cell membrane, and this is something that people don't know. This is my theory. You can challenge me on this afterwards if you like, but cancer starts in the cell membrane. You can't suddenly get mutations in the nucleus without it passing through the cell membrane. So the cell membrane is affected by the abnormal microenvironment, and everything that happens with that, and I'll go into more detail about that in a minute, and that'll fire up this these two key pathways, nuclear factor kappa beta and STAT3, and they then switch on and make some of the pathways in the cancer more active, so the glycolysis and the oxphos. So this is just a quick, again, another bit of my metabolic map here. And once you have the glycolysis happening, you have a secretion of lactate. So this is very acidic. The environment doesn't like it, and you then grow lots of excess blood vessels in order to take away the lactic acid. So you get these growth factors and also MMPs, which tend to be a little bit forgotten with general oncology. And then once you've got all of that going on, this kind of switches off the environment. The acidic environment switches off the immune cells. It switches the macrophages from being anti-cancer to being pro-cancer. You have M2 macrophages, and you also get the shift in the balance of Th2, which is more of your humoral response to more of your cellular response, which is anti-cancer. And once that's happened, you then get this fast cell division. So that's a very quick précis of what happens. So the beginning bit is really key, though. And what I might do, I called the talk Beyond the Metro Map. We may actually go backwards and look at what happens more before we get all these changes. So we don't have a cure for cancer. Stage 4 is still deemed to be incurable. So I'm going to discuss my thoughts on why I survived. Had a quick chat about the metabolic metro map. We'll go into that maybe a little bit more. And the undruggable cancer stem cell, it is druggable, okay? And these things that are happening on the cell surface, Wnt, Notch, and Hedgehog, which are also deemed to be undruggable, but they are, and I'll show you what will target those. So we have, I would put the biggest problem in oncology is not that we haven't got the treatments, but we just don't put them together and use them in the right combination. So too often lives are tragically ended, not by cancer, but by the bureaucracy that came with the nation's investment in the war on cancer, by review boards, FDA, and by the doctors who won't stand by their patients or who are afraid to take a chance. And I'm afraid I have been let down multiple times by doctors. I did have some fantastic doctors, but I had some truly awful doctors who would not take a chance on me at all. And I had to really push to get the treatments that I wanted. So stage 4 cancer patients are normally seen as terminal, final stage. That's it, end of the line. You might be lucky. They might give you some chemo. If they give you high doses of chemo, I think that will probably kill you, in my view. You might be lucky, get a first line and then possibly a second line of treatment. Those things can be very useful if they're targeted. But the ultimate is that doctors expect you to die. So for me, I added several things, diet, supplements, exercise, and off-label drugs. I also did things like manage my stress and try to increase my sleep, all of those things. are important too, and I'm still here. So this is looking at the data of my antigen levels and what happened when I was diagnosed with stage 4. So I had cervical cancer, first diagnosed in 94, and then in 99 it came back in my lungs. So nobody thought to test my antigen levels before I became stage 4. 150 is the normal range. I think when I was diagnosed, I was about 250 or something. But so before surgery, that's where I was. And then immediately after surgery, and surgery is a big problem. It has a massive effect on metastasis. And I think this is one of the things we could really, really improve, is by having better cocktails that are given around surgery. We know that there are certain stress factors, catecholamines, all sorts of things that will actually promote the spread of the cancer. Propranolol, statins, really important pre and post-op. There have been some fantastic work on that, and also non-steroidal anti-inflammatories. Ketorolac for ovarian cancer, for example, can be hugely beneficial. You can stop the metastasis by about 20 to up to 70%, which is mammoth. So we could be really stopping the progression and stopping this flood of people getting excess, all of these excess cancer deaths that we're getting now, if we actually just looked at the timing of when we did things, when we actually start to give some of these off-label drugs potentially. But there are some very good articles, and I can find those and send them out if people want to see them afterwards. So post-chemo, my markers shot right down. Now, this is where I should probably put my graph of berberine and chemo being massively useful. I've got it in my book. I've got one graph. This is for brain cancer, but it does affect other cancers as well. But in brain cancer, if you have berberine, it has a cancer kill of about, it's quite high. It's about 80% or something extraordinary. But then if you add carmustine, this was a trial done with carmustine and berberine, then you get a joint cancer kill of about 93. But the carmustine has about a 40% cancer kill. So berberine actually is much more effective. And metformin, which is like the drug form of berberine, it will actually have a cancer kill of about 40%. And then temozolomide will have a cancer kill of about 40%. But the joint combination of the two shoots it up to about 90. So I dropped right down having berberine. Berberine was one of the first supplements that I really got into, but it wasn't actually a sort of oral supplement back then. It was a tincture. I couldn't get it as a supplement, but it's become more and more accepted to be a really, really powerful anti-cancer supplement. So I then bounced around with my markers a little bit for a while. But this is where I had intravenous vitamin C, and my markers dropped way down to the lowest they ever were. Now, during that time, I was doing detox. I was taking artemisinin. I was trying to get rid of parasites and readjust my gut. So I was on a fairly restrictive diet at that point. And I took a whole bunch of these things here, but the artemisinin, sulforaphane, if you look at this, all of these supplements will actually have an effect and stimulate this ferroptosis process. If you don't know what ferroptosis is, it's kind of a new way of killing. It's not a new way, it's just a newly discovered way of creating cancer cell death using iron. So I'm not saying take iron, but this is the way that we're getting some more effective remissions. So I was tootling around. I thought I was doing okay using all of these natural approaches. And then in 2003, I started to feel horribly ill. I got really tired. I was short of breath, and I had some blood tests done. You could see I had myelodysplasia, and I had this PKM2 test done. PKM2 is pyruvate kinase M2. This is only there in cancer. Okay, so it was way up. So normal level for that should have been way down here at 15. I was near enough 400. So at this point, I was panicking because myelodysplasia leads to AML, and AML is horrifically tricky to treat, particularly if it's a result of the radiotherapy and the chemo, which I'd had as well in massive doses. So I'm not really going through my thought process of why I picked these things, but there were specific thought processes which I write about in my book. But the combination of dipridamole and lovastatin are excellent. I'll talk about that with Metromap in a minute. The atodolac is that non-steroidal anti-inflammatory normally used for arthritis. So that combination was hugely effective, dropped my markers way down within about 7 months. So during that period, I was just taking the drugs. But in fact, I actually took some of the drugs only for about 3 months because I didn't know what I was doing. I was my own guinea pig. I didn't know whether, I was actually more focused on the natural side at this point. I didn't want to be taking the drugs. And then I was okay for a while, went off the rails the next year, went to Ireland, did a sailing event, drank all the wrong things and Guinness and Murphy's and all sorts of things, was in a mess. And my markers started to shoot up. That's sort of like an exponential climb there, at which point I panicked. And then I start taking my cocktail again. I'd actually dropped the berberine at that point. I don't know why. I just forgotten about it. But then I put it back into the cocktail, and whoosh, my markers came straight back down into normal range. And then they sort of slowly climbed a little bit, bounced around under the normal range. And in about 2006, 2007, we had bird flu scares. And I didn't know I had cystic fibrosis at this point. I'm a late diagnosis, but I was really suffering from a lot of infections. I wasn't quite sure why. I just thought it was a result of the chemo and the lung tumors. I just didn't know anything else. So I looked into cimetidine because that was recommended to try and boost your immune system. And in fact, I'm just taking it today. So I take 400 milligrams in the morning, 400 milligrams at night. And this helps to reverse that Th1, Th2 imbalance that you get. And it worked with me. So from that point onwards, and metformin was also something that I started taking at this time as well. So cancer cells are addicted to nutrients, and when they can't consume enough, they just wither and die. And this has been noted in many trials that have been done at the Abrahamson Cancer Center in Pennsylvania. So starving cancer, to me, I think is crucial for people to actually get long-term remission. And you can do that in these key 4 ways, okay? Diet on its own doesn't work. The supplements, you have to be lucky. If you have a slightly earlier cancer, you may get away with less of the drugs, but really my advice is to look at all 4 things, really, if you've got stage 4 cancer. Cancer's always hungry. It is vulnerable to nutrient deprivation, and it does depend, certain cancers will depend on specific metabolites. So some will depend more on asparagine, some will be more on arginine. Most cancers are very hungry for both glucose and glutamine, but there are specific amino acids which are unique to different cancers. So we can go into that a little bit more with questions afterwards. So dietary restriction doesn't result in immediate depletion of the nutrient at the tumor site, compromising the anti-cancer benefit. So in other words, it doesn't work on its own. And also it takes time for these things to work. You have to persevere. And I know a lot of people think I'm just pro-ketogenic or something. I'm not. I do think the ketogenic diet can work very well at the beginning of a cancer journey, particularly if you are metabolically a bit of a mess. But after about 30 days, it starts to do that alteration. It sort of works its way around, it reroutes itself and actually finds different ways to resist the ketogenic diet. So why don't more doctors prescribe off-label drugs? Because they are mostly cheap, mostly very low toxicity, and they do enhance the treatment efficacy. So legally, doctors can prescribe them happily if they're acting in the best interest of the patient. But terminal patients, and I found it hard to access doctors who are able to prescribe on this creative compassion. But my oncologist back in 2003 was the one who prescribed the lovastatin and the atodolac, because I gave her information to show that the combination of the two was 5 times better to create a cancer kill than one or the other individually. And back then, she was lovely, one of the good doctors, and she prescribed those for me. She'd been looking into statins herself, and she didn't know which one would be best. And lipophilic statins are, in fact, the best ones for cancer. So atorvastatin, I took lovastatin at 80 milligrams, but atorvastatin, simvastatin, and now there's a super statin called pitavastatin, which shows fantastic results in ovarian cancer. I know we've got somebody with ovarian cancer listening. So doctors are focused on these randomized clinical trials, but just because there isn't a randomized clinical trial doesn't mean the drugs don't work. You need to look at the epidemiological evidence, and there is quite a lot. I say quite a lot, there's enough to substantiate the use of metformin, statins, particularly the COC, the care oncology drugs, doxycycline and mebendazole. And of course, there's no financial incentive if you're going to use an off-label drug, because they're too cheap and you don't get your money back on them. There's also this patent cliff with most of the big pharmaceutical companies. So they're getting to the end of their life with their patents. So this is why they are trying to develop some metabolic drugs. They haven't really done many so far, but this is why we've now got this repurposing movement, which is fantastic. Hooray, hooray. So combinations. This is what my big thing is all about, combinations and metabolic flexibility. And I think it's really key that people understand this, because if you use a drug or a supplement, it can switch the way that the drug is working to use another, the cancer will use another pathway. So you need synergistic combinations that work together to create what's known as synthetic lethality. That would be the ideal. And I'll just leave that there for a minute while I go on to the next bit. So this is my theory, looking down on the cancer cell on the more of the genetic mutations. Cancer is a mix of both genetic and metabolic changes that are happening together. They influence each other. If you look at some of these keys, these are just a handful of some of the key gene mutations that you get. So the P53 gene, for example, if you have the wild type, it's very good at promoting things like ferroptosis, which is cell death. But if you have a mutated P53, it will promote the glycolysis and the glutaminolysis. c-Myc as well, that's more the glutaminolysis. The BRAF, the KRAS, EGFR, all very pro the glycolysis. But they all have their own specific set of favored pathways inside the cell. So looking down at Piccadilly Circus, I don't know if anybody else is from the UK, but this is a very busy place. And if you're looking at these key pathways in the cell, those are these big roots, the P53, the c-Myc, the BRAF. These can be very big drivers for the cancer. But what you don't see is underneath. And Piccadilly Circus is here. This is a London tube map. And just to explain what I mean about this metabolic flexibility. So if you're blocking, say, this route here, which is the Bakerloo route, then the cancer can then just say, okay, well, I can go this long route, I can go all the way around here and eventually get back there, or it'll find a shortcut and then go straight back into Piccadilly Circus using another route. So there are, and this is exactly how the cancer tends to work. And this works with drug resistance as well. So if you look at many of the drugs that are used in cancer, common chemotherapies or immunotherapies even, but the targeted drugs in particular, if you use a targeted drug, you will find there are metabolic pathways that get switched on. And if you can work out what those are, and you can look in the literature, you'll find quite a lot of it being reported now. You can work out which bits in your map you need to actually block when you're taking these targeted drugs, so that you know you'll get much better result. You'll get the drug to work that much longer. Okay, so this was my initial thoughts way back in about 2012 when I was trying to work out what I'd done. So dipridamol actually blocks nucleoside salvage, so it stops the uptake of nucleosides. I didn't know it also has a big effect on the cholesterol as well. So metformin and berberine both block the glucose. They also have many other effects. I'll go into that in a minute. And the fat I was blocking with the statin. But actually, if you look at this and the care oncology drugs that are used, so if you look at what, and if you've, I'm assuming people know who the care oncology clinic are, although, anyway, I won't go into that, but they may not be around for much longer. But you've got metformin. So up here on the left, it helps to block IGF-1. It also blocks the OXPHOS, which is on both sides. So you've got it there, and you've also got metformin over here. It helps to block mTOR, which is a key protein sensor. And then it also helps to, reduce, well, actually increases insulin sensitivity here. And then down in the fatty acid pathway, it's helping to block that alongside aspirin together. Metformin doesn't work on its own there. So it has a multiple number of pathways that it'll block. So this is a very basic, this is like the key ones, not comprehensive, but this is just a little snapshot just to give you an idea of the key pathways. Statins, so people are very anti-statin. There's a lot of bad statin press out there about how it's going to reduce your CoQ10 and how you'll end up with dementia, etc. Now, CoQ10 is a very powerful antioxidant, and actually, if you're having chemo, if you're having treatments, you don't want CoQ10 in your system, and particularly if you're trying to stimulate ferroptosis, you want to reduce the CoQ10 in your system, and this is why it's important to look at statins in the cocktail. But actually, if you're going to use metformin blocks something in the normal Krebs cycle, the OXPHOS cycle. It blocks something called the complex 1 in the electron transport chain. And if it does that, what it does is it actually creates a reverse shunt of glutamine, will then reverse shunt and then actually pump out citrate, which then gets converted in cholesterol. And then that's where you need the statin. So the combination of statin and metformin, I'm sure Greg, who started up the Care Oncology Clinic, thought about this long and hard, but actually the synergistic effect of actually blocking those two pathways was really good. And then I took the statin and dipridamol here. So this is like, I call this my cholesterol corner. So these are two key cholesterol pathways. Every cancer cell will have cholesterol blobs on its surface. It wants to create, is constantly trying to churn out cholesterol to create these new membranes. And I blocked both with the dipridamol and the McLelland. I didn't really fully understand what I was doing back then. I was just had my L plates on, but I obviously picked a good duo there. But if you look at nucleoside salvage for the dipridamol, so what I was doing was stopping the cancer from pulling in little chunks of DNA. But I was also blocking this other pathway, the pentose phosphate pathway, which produces DNA. That's one of the things it does. It also produces glutathione. which is a key antioxidant. But I was using DHEA. So if you don't block both of them, then it'll just switch from one to the other. mTOR and autophagy are, again, two key pathways that sort of feed off each other. Macropinocytosis, I know somebody has got pancreatic cancer. This is a key pathway that pancreatic cancer uses. You need to look into that. Hydroxychloroquine is something that Steve, I can't remember his surname, but he's a doctor. He took a very high level of hydroxychloroquine for about 3 to 6 months, gradually reducing it a little bit. But he also took metformin, statins, aspirin. He did the full cocktail of things as well. Not through my research, he did it himself, but he also had it alongside an immunotherapy. So this isn't alternative, it's complementary, and he's still cancer-free. So what's his surname? I'll try and remember so I can put you in touch. So these are, this is my second edition one again, and just to run through some more of these. So glucose will normally go into the muscles through GLUT4, but in cancer, it goes through GLUT1 or mostly GLUT1, but sometimes 2 and 3. And in fact, it will also use GLUT5. So prostate cancer, for example, will use a lot of GLUT5. So it likes the fruit, but it doesn't like, so actually, when you look at PET scans, they don't use PET scans in a classic way normally for prostate cancer. They will use choline as a tracer because it's looking at the fat uptake, because fat is critically important for prostate cancer. So these pathways down here, and in fact, statins and dipridamole, there's good research on that combination working really well for prostate cancer. There are some other things like, I haven't got it, well, the FABP5, which is the fatty acid binding protein 5. That is really important as well. So you, and berberine, hopefully someone's going to get that at the door. Berberine will help block the acetate as well. So that there are, so I actually think berberine may be better than metformin for prostate cancer, but that's not to say I wouldn't suggest that you avoid metformin. So that's just a general overview of the map. Glutamine is for prostate cancer, the proteins are actually quite important too. So you've probably seen that ursolic acid, curcumin, and resveratrol are really good at helping to block the uptake of glutamine with prostate cancer. Just a quick overview. Okay, this is what doctors are taught. I'm not going to go through this much, so don't panic about this. But this is looking at what doctors are taught, but you can't see any glycolysis in there. There's no mention of autophagy or, you know, the Krebs cycle, nothing. It completely ignores the metabolism. And this is where we're going wrong, is that doctors have no clue about that part of what's going on with the cancer cells. So it's looking at, it's got Wnt and it's got hedgehog there. I don't quite know where the notch is on this. They've forgotten that. But they're, you know, these pathways, you've got STAT3 here and you've got nuclear factor kappa beta here. But otherwise, I just feel it's just missing some of the key metabolic pathways for doctors to learn. They just don't know it. So we're just going to talk a little bit about the cancer stem cell, which is a slower dividing part of the cell. So that's actually, you know, if you're going through the progression of cancer, it is where my stem cell is the sort of the progression between the different metabolism to going on to the growth factors. It's between the sort of the tumor environment stimulates this sudden increase in activity in the cell with the mitochondria. And then once you've actually switched off the immune system, that's kind of like the fast dividing cells there. But everything before that is really the cancer stem cell. So they are a smaller population, so you don't get so many of them. So in You know, you only get 1 per 10,000 in the tumor, and they are phenotypically diverse. In other words, they form all of these different types of tumors. They prefer different fuels, different metabolism. So these are the 3 key features of stem cells: this plasticity, its ability to switch and change; senescence, which is this old cells which just hang around and secrete, I think they're called SASPs, which stimulate the cancer cell to progress as well. And then you've got quiescence. So how do you deal with those things? So the MetroMap kind of deals with that plasticity. Senescence, you've got some fantastic, Tanib is brilliant. Quercetin and Vistin, very good senescent drugs. Senolytics is what they're called. And then BACL2 inhibitors will help with the quiescence. So really, you probably need to have all of those things in your cocktail. You need to have some key inhibitors of the MetroMap. You probably want to have quercetin, which is great anyway for blocking that GLUT1, and Vistin, which is actually kind of a natural PARP inhibitor, brilliant. And then there are actually quite a few natural supplements that will inhibit the BACL2 as well. So going back to this, that's the basic chart. You've probably got a fair idea of these things now. And if you want to ask me some more questions on that in a minute, that's fine. So if we look at progression, at the moment, we're targeting the fast cell division with chemo and radiotherapy. That was kind of like the start of how we used to treat cancer. And then we progressed to sort of trying to hit the growth factors, the VEGF, the vascular endothelial growth factor. And then we moved on. We're now in the sort of immunotherapy. It's like a big thing. But the next phase, we'll be looking at these RNA vaccines. But actually, these will, and I'll talk about this in a minute, these will help target some of the epigenetics that's going into the cell. So this, I think, could be very hopeful, you know, as long as we don't have any spike proteins in there. I think but again, we don't know what the results of these RNA vaccines will be. So if you look at some of these factors in the tumor microenvironment, you've got this Wnt, Notch, and Hedgehog going on the surface. Then you've got these toll-like receptors. These are pathogen receptors. Pathogens are huge. We know that inflammation, IL-1 and IL-6 are inflammatory markers, and the biggest inflammatory cause is really infection. But you've got other things causing it as well, carcinogens, you've got obesity. All of these things will cause low-grade inflammation. And then you've also got HIF-1 alpha, which is hypoxia-inducible factor. So this will drive cancer as well, a lack of oxygen in the area. So if you're going to target interleukin-1, these are good things for that. Curcumin, fish oils, boswellia with high ACBR and non-steroidals. And interleukin-6, berberine and red yeast rice together work really well. Ivermectin, dipyridamole, and fish oils, again, very useful. So, you know, a lot of hoo-ha over ivermectin, but it is a very useful drug for cancer, and it will help in the MetroMap as well. It helps block some of those pathways. Those toll-like receptors, low dose naltrexone helps on those, and CBD. The pancreatic person, you've probably seen the research on low dose naltrexone, and what did they use? I can't remember. It was a combination of LDN and another drug together. But again, I think CBD can be very useful for many cancers because of its effects. And then you've also got galectin-3, which you probably know, as we got lots of prostate cancer people here, this is a very upregulated feature. So it's a type of lectin, but modified citrus pectin. I don't know whether you've talked about that before in this group, but it has very big effects on prostate cancer. But galectins can also affect other cancers as well. So you can look that up and see whether it's affected you. Galectin-1, I think, actually for cervical cancer. And I'm not sure whether modified citrus pectin works on that, but I did actually take it anyway back in the day. Then HIF-1 alpha to try and block that factor. We've got noscapine, which is actually, it's a drug that is, it's a cough medicine. It's used for kids in Holland, but in fact it's from the opioid poppy. No psychoactive effects with it though. And that is really useful. It also works a little bit like mebendazole in terms of blocking the microtubules in the cell. It's a more gentle sort of microtubule disruptor, a bit like vincristine or vinblastine. So it does almost work a little bit like a chemo as well. Acroflavine, to get it orally is quite hard, but that, if you want to look up acroflavine for cancer, there's some tremendous stuff on it, but we need to have it orally, and getting that, you can get it in Mexico. And chrysin, which is from honey, very good at helping to block hormonal problems, as well as the HIF-1 alpha. So if we look backwards a little bit, do you want me to stop, or how are we doing? I'll just a few more minutes, okay? So we'll go backwards a little bit to what happens with the microbiome, because this is an emerging hallmark. And this is my theory of what happens. It stimulates these toll-like receptors because you get a leaky gut. And most people with cancer at some point will have had gut issues. And you get a leakage of some of these pathogens into the system. So they cause inflammation and they stimulate these toll-like receptors. And I suspect they have an influence on Wnt, Notch, and Hedgehog as well. I'll tell you why in a sec. But we have, so this is the leaky gut with all of these pathogens. And then you have something called exosomes shed from all of these pathogens. Cancer cells shed these exosomes as well, tiny little nanovesicles, which communicate with other cancer cells. So the bacteria communicate with other bacteria. You get this big network of communication going on in the system. And these exosomes contain a lot of these RNA particles, as well as protein, lipid, and glucose. And this is where I think these, this is the epigenetics that happens. It's a sort of the knowledge from what's happening in the tumor microenvironment going into the cell. So I am hopeful that the mRNA or the RNA vaccines will do something, but let's wait and see. And to block exosomes, you've got CBD, and another really useful drug actually for cancer is amiloride, because this also affects the extracellular pH as well. But if you look at the antimicrobials with anti-cancer action, you've got a lot, from doxycycline, clofazimine, which is used for leprosy, really useful for triple negative breast cancer. In fact, quite a lot of cancers. Nitazoxanide, which helps with ferroptosis. Niclosamide is big. It's big, big, big. Sort of like the two big anti-cancer drugs are sort of niclosamide and mebendazole. A lot of people use fenbendazole, but niclosamide, because it works on the cancer cell membrane, and it helps block many things. It blocks protein uptake, and it helps promote ferroptosis. It has a huge effect, but unfortunately, it needs to get into the system better. And that's something I'm working on with a professor in America. And you've got some more of these antiparasitics as well, which are terrific. And if you actually look, we're going back to looking at sonic, hedgehog, Wnt, Notch on the surface of the cell. These things will actually block. So this the undruggable targets of Wnt, Notch, and hedgehog are not undruggable. Nitazoxanide helps block Wnt, imicrimod, the hedgehog. Niclosamide will actually block Notch, Wnt, and STAT3. Nifuroxazide, JAK2, and all of these will block the hedgehog. Ivermectin will block the Wnt, itraconazole, the Wnt and the hedgehog. So a lot of different targets from these antimicrobials on the surface of the cell, really big. And what you want to do is work upstream, because that's the way we're really going to affect cancer. And that's why I'm hopeful that these RNA vaccines will do well, because they are more upstream than a lot of these chemos, etc., which hopefully will one day will phase out chemo, or maybe just reduce it. That's what I'd like. I mean, it's not to say it's completely redundant, but I do think we overuse it. And just to finish, just to say, cancer is heterogeneous, so you need to find your metabolic phenotype. You need to do a bit of research, having a look to find out which pathways are most upregulated with your cancer. And you can use Perplexity, you can use Consensus, you can use ChatGPT. There are many different easy ways these days to look at the phenotype of your cancer, because different cancers use these different pathways. So maybe glycolytic, cholesterol loving, etc., etc. So I will leave it there and wait for the torrent of questions.
So Jane, normally we have like 10 more minutes till the top of the hour, just so I know to sort of manage things. Can you run over a bit, or should we try to stop at the hour for your schedule?
I'm happy to run over. I've got nothing else after.
Okay, that gives us a little more room. Thank you. So I'll moderate. We'll use the raise hand feature. So if people have questions and they use the raise hand feature, then I'll call on you. There's been a lot in the chat, Jean. I don't know if you can see the chat, but there've been a number of people who've been making comments there. One theme is, and this is always sort of an issue when you get into the complementary therapies, et cetera. You're talking about molecular pathways, and the question is there evidence? And of course, the gold standard, again, comes back to randomized clinical trials. And as has been pointed out, sometimes it's evidence-informed, not evidence-based. And so how do you, I think there's two questions. One is, how do you come up with the pathways that you focus on your model? And then second question, what is the evidence that supports the recommendations you're making?
Okay, so there is epidemiological evidence which goes back to looking at people's, so if you're looking at metformin for diabetics, etc., there's a study done in 2013 looking at 15 million, I think it was, 15 million diabetics who were taking metformin. And also there, I don't know whether it looked at non-diabetics as well, but certainly there was a significant decrease in the number of people who were getting cancer. Statins they've looked at in, I think, Finland. But it's looking at the combinations which is key, because if you're not looking at the right combinations, and this is what we're lacking, is actually more clinical trials to determine exactly how, whether these things should work or not. So in GBM, for example, the Care Oncology did a study looking at their 4 drugs, the bendazole, the doxy, the metformin, and the statin together. And they showed that they doubled survival time. They were also looking at triple negative. They were looking at a whole range of different cancers, and across the board, they couldn't publish all the results, but they were seeing a doubling of survival time. Having said that, I know anecdotally, which is just a terrible evidence base, but you do have a lot of positive progress reports, and they're not always reported in my Facebook group, but I have a very active Facebook group which everybody's fine to join if they want. It's called Jane McLelland Off-Label Drugs for Cancer. Got about 93 or 94,000 people in there, and they will often report their positive progress and then write down what they've used. It's not, the N of 1 it's unfortunate that that's where we are right now. But if you are stage 4 and you know that they haven't got the answer, what are you going to do? Are you just going to sit there and die, or are you going to have a go and try and look at different ways to actually save your life? And this is the issue that we have. Doctors hate it because they want everything to be for the long-term good, they're thinking that everybody should be a guinea pig and sacrifice themselves for the future good. But I think we need to look at trials in a different way. We should look at trials at looking at better cocktails. And then once we got the cocktail, work out what we need to cut out. So I think we need more and not less. So what they do is they trial one drug and then they trial, this is not the way to do it. We need to be trialing a cocktail together, find out which cocktails are the most effective for different types of cancer. And we know that pitavastatin for ovarian cancer works really well. You get a 40% increase in survival with statins if you take for ovarian cancer. And pitavastatin is particularly useful, but you need to take it at a high dose. However, if you take ivermectin, you can reduce that dose because it's synergistic. So ivermectin and pitavastatin look to be super, super good for ovarian cancer. But again, that's just part of the cocktail, which would be really good. But so you just have to look at the research, and just because those randomized clinical trials aren't there, doesn't mean to say it doesn't work. That's all I will say about that.
Okay. Just a broad question. It's something that I don't think you touched on too much, but I know my friend Brian always asks this question, and that's diagnostics. So you have many pathways, you have many drugs, you have many options. Are there things that you can do from getting tests and diagnostics that predict whether someone will respond to this particular pathway, this particular drug?
Well, yeah, I mean, I'm not in a lab, so that's not something that I can do. But Chris Apfel over there, I can see. Hello, Chris. He's somebody like him can actually take some tumor sample and actually look at the different things that will work with it. So I mean, I want to work a little bit more with Chris about looking at which cocktails might work, etc. Just to see where we go with it and to actually gather some more evidence. I think it's important. And I like to have my N of ones in my Facebook group and then try and pick through whenever somebody writes a positive progress about what they've done and they've got themselves to no evidence of disease. I like to pick through and think, aha, they've used that with that. And then that's okay. So that's blocked that. And then I try and work out the strategy of what they've actually done in order to achieve NED. Very tricky. And obviously, I don't know everything. So I can't absolutely guarantee I know what they're doing. But, I can get some idea of what they've actually done and how it may have actually worked. So I think coming up with some cocktails in the future is something I would love to do, to work with a lab to try and create some cocktails for things like pancreatic cancer. I'm like itching to have my own clinic and actually use some cocktails to try out. And ferroptosis is particularly useful for certain cancers, and pancreatic cancer, for example, tends to respond to ferroptosis treatments much better than many other ones. And KRAS colorectal cancer responds super well to ferroptosis treatments, which is using intravenous vitamin C. But because it's intravenous vitamin C, you don't have clinics using that. It's very hard to get your traditional doctors to look at that. They're still absolutely obsessed by the fact that they think that intravenous vitamin C is antioxidant, whereas in fact it is actually reacting with the iron cell, and it's pro-oxidant. It's releasing hydrogen peroxide into the area. So it's not antioxidant. It's a completely different effect.
Brad, maybe if I could just jump in here, add a little bit of clarity to the question. Jane, are there certain basic tests, like blood tests, for example, that would provide clues in terms of any supplements that we should be taking? And then I would take that one step further, since you talked about microbiome, right? What about microbiome tests, right? So those are two.
I think that's key. I did that. I certainly had my gut microbiome tested to see whether I had sufficient bifidobacteria and lactobacillus, and Akkermansia is really key. in the gut as well, and butyrate will help as well. So that there are certain things that you definitely need in your gut in order to create the right environment. In terms of actual tests, so I did the PKM2 test. So that's the pyruvate kinase M2. And that is a test that looks at glycolysis. You've got LDH as well, lactate dehydrogenase, which again is another glycolytic enzyme. So you're looking at those two, you can get some idea. Now looking at glutamine, what do? I've looked at this hard to try and find some sort of blood test to see whether you can find out whether the glutamine is a big problem or not. And I'm not sure that there is one, sadly. But what you can do is look at your homocysteine levels, because methionine can be very raised sometimes, and that will, provide that actually converts into homocysteine, and then that provides cysteine, N-acetylcysteine, to sort of create the antioxidant, which will prevent the cancer from being killed off by oxidants. It's a way of preventing the cancer from being killed off. So methionine is another thing, or homocysteine is another test I think people should look at to look at that. ESR might give some idea if there's infection going on. What else?
Sorry, and these would be tests
Yeah.
that would come from like a microbiome test. These are not, this is strictly
These are
microbiome
blood
testing?
tests.
Well, blood tests,
Well,
okay.
no, these are blood tests. These are
Okay.
actual blood tests that you can do.
Okay.
Yeah. Yeah.
Are these listed somewhere? So I could get sort of like a comprehensive list?
I have got them in my ferroptosis chapter.
Okay.
But otherwise, no. And I was going to speak to Life Extension and do a panel with them of tests, because I don't know anybody who does the PKM2. I was very lucky. I had a Russian lady who had developed this test, and she happened to be living in England at the time. I think she still is here. I'm not sure, but I don't know many people who use the tests anymore. But for me, it was very useful, and I think it would be useful for other people as well. But in terms of actually determining what your cancer is feeding on, we should be doing PET scans to look at glucose, glutamine, choline, kind of like merging them all and seeing which one is actually lit up most, to try and get an idea of what it's doing. Then there must be other. I'm going to go to a conference in Bilbao. It's the EACR metabolic conference, and Matt van der Heijden will be talking, and he's like spot on with this kind of thing. So I'm going to, this is part of my mission, is to try and find out those kind of tests that we can run to really try and fine tune what we're looking at in the cancer patient, because otherwise it is a bit of guesswork. But you can find key phenotypes that the cancer will use, so that we know that pancreatic cancer, for example, will use macropinocytosis. It's also got a thick stroma, so we need to get through that. There are lots of different features that we know about different cancers that we can work on, that aren't necessarily, attacked by the traditional oncologists. They're not necessarily looking at the metabolic features of the cancer. So you can do the research, use Perplexity, use Consensus, use ChatGPT. I don't favor ChatGPT that well over it, but Consensus and Perplexity, I think, are great for trying to work out the phenotype of different cancers. And you can do a lot of research there, and you can find out which of those pathways on the MetroMap are really key for you.
I'll reach out to Rob Knight. He runs a whole gut microbiome center here at UC San Diego. Let's see if maybe he can kind of coalesce the work that you're doing and what he's doing with microbiome.
Yeah. There's some it's very, very interesting that, William Lee is very much pro the whole. So he uses fecal transplants and does all sorts of things before giving people immunotherapy now. And the difference in the result is quite phenomenal. So it's a big thing.
Great. Thank you. I don't want to hog all your time. I know there's other people that want to jump in here. Thank you.
There's some specific questions I see about GBM, pancreatic cancer. We've got ovarian cancer represented. There's some comments about prostate cancer, and the comment being that some of these drugs are hormone driven. And so how does that interact with the metabolic analysis you're doing? So anyway, just sort of any things that are sort of going through those cancers and some of the questions in the chat.
Yeah, okay. So if we're looking at hormones, if you roll back from the ultimate, so you get more testosterone in prostate cancer, you get more estrogen in breast cancer. But actually the triggers for that, when you look back and you sort of run it backwards, you've got inflammation, which kind of drives it. And the mevalonate pathway, which produces these hormones, also is involved. So you get, so that's another reason why statins could be very useful for prostate and breast, and the fat side of it, because of the hormonal implications. But there are, obviously that's something, well, I cover more of that in my online course, blocking the hormones, but it's obviously going to drive a lot of the growth factors. That's what it does. Estrogen is, stimulates growth. So it's more dangerous than testosterone.
There are no more hands raised, so I'll just, again, looking at the chat, there were a number of questions about access to doctors in the U.S. who follow your practice and your models. And someone pointed out that you have a list of doctors in the U.S. that can be found. Is any comments sort of on access to your work? And I know you said you're running a course or something with a discount, so on.
Yeah, I've got a teachable course, which effectively just breaks down all of those modules, the sort of the right from the tumor microenvironment through to the fast dividing cell, to looking at things like the cascade and how to increase the death of the cancer. That a whole load of info. So that's available. And if you want to get hold of doctors, if you go to my website, which is howtosolvecancer.com, I do have and go /doctors/ then you've got a list of people who are happy to provide off-label drugs. Will the Valley is there.
I was going to call on Will, just from your perspective, any comments you would have, since you're treating using similar ideas, anything you would add to the discussion that Jane just led?
I think the concept of a broad spectrum of therapeutic agents is really important, and the understanding, and I think in pointing out the example of metformin targeting multiple molecular vulnerabilities as a component of a range of therapeutic agents. The concept that I find most useful is that of molecular network targeting. And I think the way Jane presents it, I think is brilliant. It is understandable, it's digestible. And the point that we're dealing with preclinical trial data is a big issue. It's an inherently important to transparently discuss that we're using preclinical trial data in general, and the people, the doctors and their patients have the options to consider it in addition to what the conventional treatment is. And so I think there's a rationale for using these options. And the challenge, exactly what Jane was talking about, is, well, what's the best approach? What are the best combinations? And how do you know? and what way do you, how much dosing, and who's going to tolerate what. So it's inherently a molecular network approach using synergistic the construct of overlapping concurrent therapeutic intervention. And Jane's, I think, done more than anyone in presenting this information so that physicians, as well as patients, their patients and their family members, have an understanding of this.
Thanks for that endorsement. We do have 2 hands raised now, and I'll try to wrap it up pretty much after that because we're a bit past the scheduled hour. Rick Davis, you had a number of comments in the chat, and you've got your hand raised.
I did. I think what strikes me most listening to the presentation is that that Jane does not really distinguish between stage 4 cancers. So not all stage 4 cancers are equal. And there are many people in stage 4 who live for many, many years. Are they incurable? Yes. Are they terminal? Well, a lot of people may die from something else, and we see that, and we work with those people, particularly in prostate cancer, and it very much depends on the phenotype of the prostate cancer. So when statements are made like, well, take metformin or take statins, it may not apply to all cancers. And for example, for years, there's been a movement in prostate cancer to take aspirin, statins, and metformin. Started with Snuffy Myers back in the 1990s. But now there's a preponderance of evidence around metformin. It doesn't make much of a difference. I put a link to a meta-study in the chat window. It doesn't make much of a difference unless you have diabetes. Not that I wouldn't take it or suggest it if I needed it, because it really doesn't do much harm unless you take it in too larger doses. And oftentimes we'll tell guys to cut back what they're taking if they get a bunch of diarrhea. But it probably doesn't do much good, you know. It's sort of like chicken soup. It may help and it can't hurt. But
so this study that you've can I find that there? Is this looking at metformin on its own?
Yes, it's
and that is the key point. Is if you're looking, and they did a study which came out, they published it from Medscape and said, oh, metformin bombs in landmark cancer trial for breast cancer. But when you looked at the detail, it didn't bomb. It was shown to be very useful for HER2, but they didn't really. There's a lot of backlash against this because people, you know, the big pharma don't want these cheap drugs. So I would be a little bit circumspect about.
I agree with you, but like you just said, it did great in HER2. So what you have to be is more specific. So yes, it may be great, not arguing with you, but it's only specific for certain things. So this was a meta study. So I don't know how many were in the meta study. It's further back in the chat window, but you know what? I'm going to copy it and put it right at the bottom right now. So you can go to it.
I can have a look, and that's fine. And it's the same with the breast cancer one, but it was looking at metformin on its own. And like I said, if you use metformin, it blocks the electron transport chain in the OXPHOS pathway. That's one of its key things that it does, hexokinase 2. So what it does, you actually get something called glutamine carboxylation. So the Krebs cycle goes backwards. Instead of going round this way, it suddenly goes, oops, and then it will pump out the citrate instead of doing the normal Krebs cycle because of the interference of the metformin. But the cancer can learn to switch around different ways. But the key is that you just need things that will make it work. You don't necessarily need a lot of things to make it work, but you just need the right combination. And different cancers, different. So if you have a ketone loss with prostate cancer, you're going to be more glycolytic. Okay. So your cancer, your specific phenotype of your cancer and how it works may be more aggressive depending on the genetics as well. And that's something else I haven't really talked about. But those genetic features will make a difference as to how responsive you are. So if you've got P10,
absolutely, but you're making my point, Jane, which is that this presentation talks in generalities when in fact what we've got to do is almost look at this like it was a precision medicine and start at the bottom and find out what microbiomes you have, do a next generation sequencing, find out what mutations you have, and then we build on what you are with what you have.
And it gets expensive, tricky. All this test, assess, redress stuff can be phenomenally difficult for people to keep looking at all this stuff all the time. And it's we have to try and make it accessible for people to do. And you've got to cut down some of that noise, otherwise you'll never get anywhere.
Yeah, we do, but you know, it's more expensive to buy all these drugs, even if they're supplements, when they don't work, than to know what will work and then buy the specific supplements for your particular case. So when we make these because we have guys come into our and women come into some of our virtual groups, and they say, oh, this one says get this and this one says get that. The issue is it going to work for you? It's not one, it isn't one size fits all.
And that's exactly the point. It is that it has to be more personalized, and this is why you have. I mean, have you used Perplexity or Consensus AI to look into, and they will be able to give you in vivo results rather than in vitro. You will get specific information as to whether it's a drug that's been used in mice, or whether it's been used in humans or whatever. So you'll get more information, and of course, the best evidence is in humans, but we don't have that with most of the off-label drugs, and I don't think we will ever have it, and this is a problem. It's a big problem. So how do we overcome that, and how do we get to the point where we say this is a cocktail that will really work? And I think all we have to do is just keep going and build up the numbers, build up the data, and have people like Glenn Sabin or whoever, or Xcures, whoever it is, building that data, that platform, to say X number of people have used this cocktail and it's worked for this number of people. That's what we need to do. And I don't think we will ever have the information that we really want. And it's a problem because of the financial incentives to do these tests. They're just not there unless we have some very, very generous philanthropists who actually put some money forward for us to do it. So we're always going to have this argument, oh, there aren't enough RCTs. It's going to be my endless argument about it, that we will have to say that we'll have to look at the best evidence that we can get and work out the potential metabolic pathways that you specifically have, depending on your, the phenotype of the cancer, the genetics that you have, those mutations, what they are actually going to do to you, to your cancer, and then look at the best combination that we can from that perspective.
In the interest of time as the moderator, I'd like to wrap up and give Jane a chance to say a final word. Any closing comments you would like to make before we adjourn?
No, I think it's been great, and I kind of knew I'd get the RCT. There's no evidence. That was classic. That was expected, but there is evidence, and I do encourage people to use some of the really good AI that's available now, to have a look at their particular phenotypes for their own cancers, because it's very useful. And they will come across, if you haven't done much research into off-label drugs for your cancer, start doing a little bit of hunting around and become maybe a little bit more comfortable with it, because it worries me that some people don't start. A lot of mistakes that people make with cancer is that they don't look at this extra information that's out there. They just focus on what the doctor said They don't worry about their diet. They don't worry about exercise. They don't worry about all of these other things, the stress, etc. All of that, all of that needs to be taken into consideration. It all has a bearing on how well you're going to do with your treatment. So yeah, it's maintain an open mind, and I'll leave it at that.
Just mechanically, I'm very curious because I'm very comfortable using AI and Perplexity and so on. What do you input? Do you take your medical record? Do you take your test results? What do you input into Perplexity to say what's the customized treatment just for me?
Well, you have to be quite specific about it, and I think you have to say, and I won't necessarily get the right answer straight away, because you can say what are the key metabolic features of prostate cancer, won't necessarily tell you the right answer, and then you have to break it down to, is arginine involved in the metabolic for driving prostate cancer? And then you have to sort of you have to be more specific about the types of amino acids, etc. And then you have to go into those pathways. And that's my job, is to educate people what those pathways are. That's my metro map, because otherwise, how do you know what you're asking? How do you know to get the information without knowing what those pathways are? And that's key. So you can put those individually into Perplexity. And you can even say, things like what off-label drugs or what repurposed drugs might be useful for blocking particular pathways, and it'll come up with, I've learned some new ones since doing it. So it's, it's a useful tool. It's a useful tool.
So you're having a conversation, is what I hear, and you're asking a series of questions about a variety of pathways. Yeah. But the question is, how do you know whether that's relevant to me? What are the things that might be showing up in your blood work, in your test results, in your history, that you would then say, this is me querying that pathway?
You have to understand, so if you have, if you know that you have always eaten a high meat diet, you know that you're probably going to be feeding more on the amino acids. That's kind of probably the way it would prefer to feed, if the nutrients are, if you've got a lot of glutamine running around the system. So your diet will have some bearing on it. Obesity as well, that has a bearing on it. Your insulin resistance, all of those tests are very useful as well, to see whether, they may have a bearing on your cancer and to what you should be doing about it. If you're very insulin resistant, you should maybe look at the ketogenic diet for a while. Okay. But it's not one that I don't generally say that to people with prostate cancer, because I think the meat and the dairy is so key in terms of cutting those out. There's a lot of evidence behind that. And I talk about Michel Montagnac, who was one of the first ones to sort of promote the more keto diet, which was meat and lots of dairy and all of that. He died of prostate cancer, and yet he was trying to work at improving his heart parameters, but he didn't end up helping himself, because he died of prostate cancer because of the meat and the saturated fat and everything else he was having. So that's his little story.
Okay. Well, just looking at the clock, I think I should stop recording here. And thank you.